Thank you, Paul. Paul, please let me know if there's any audio or visual problems that I might not know about. I can't quite see what the viewer can see. So
You
we're
got
going
it.
to dive right in. We're going to talk about our treatment for uterine fibroids. We've got a treatment that's been around for 25 years, but I think that there's still a problem with gynecology providers not telling patients about this as an option. So we're here to kind of spread the word and let patients know what other options are out there for them. So let's get right into it. One other note is that you can see on the sign behind me two phone numbers. We actually have a third phone number that we're going to put up at the end for our new Scottsdale location. So we will put that phone number up at the end. You can see that over my right shoulder here. Okay, let's get right into it. So we are going to talk about a minimally invasive approach to treating uterine fibroids. It takes advantage of the fact that fibroids are very vascular tumors. They need a ton of oxygen. Just as a little background, fibroids, this is a cartoon showing some hypothetical fibroids within the wall of the uterus. So this shows that fibroids are benign tumors of the uterine muscle. Uterus is a big muscle. Its job is to push babies out. It's a very strong, big muscle. Those muscle cells can develop benign tumors that we call fibroids. They have no cancer potential, so they're not life-threatening, but they can grow huge and cause a lot of big problems for the patient. And as this cartoon shows, this is pretty accurate. Fibroids have huge blood vessels going into them because fibroids demand a ton of oxygen to stay alive. And so we kind of take advantage of the fact that fibroids need a ton of oxygen, whereas the normal uterine muscle needs very little oxygen to survive. So we take advantage of that difference by targeting the blood vessels that are leading to the fibroids. We know that if we interrupt the arterial blood flow, which carries oxygen into the fibroids, through the fibroid blood vessels, the fibroids will die and shrink. The uterus does fine. And most importantly, fibroid symptoms, the problems that fibroids are causing for the patient, go away. So interventional radiologists have, let's go to the next slide. Interventional radiologists have developed an endovascular approach, meaning an approach we deliver through within blood vessels, using injectable bead technology as the device that we use to close the blood vessel. So you can see the beads that we use, these are gelatin microspheres. They're harmless, they're made of a harmless material. Their job is to occupy space within the blood vessel. Ultimately, they reach a vessel size that they cannot pass through, and they get stuck, as this animation shows. When a column of these beads forms in the vessel, blood flow through the beads, for the most part, stops. We actually leave a little bit of a trickle of flow through the beads. But as you can imagine, with the beads occupying all this space, blood flow does go down to a trickle. So that's fine for the uterus, but fibroids cannot survive that. Fibroids die. Using beads to blockade the fibroid blood vessels causes the fibroids to die, or we call it ischemic necrosis. And why does that work? This cartoon shows little beads in the blood vessels of the fibroid. This is pretty accurate that the fibroids get much bigger blood vessels than the surrounding uterus. But in real life, there are some smaller vessels going into the uterus. But the reason the uterus does fine with this treatment is that the uterus muscle is made up of an interconnected web of vessels that provides what we would call collateral circulation to the cells, so that if you were in this example of a leaf, if you were to use beads to occlude or close up the nutrient vessels in the proximal parts of these stems, the leaf could continue getting blood flow from the other side. So we would call this a rich interconnected collateral network. Fibroids are not so. Fibroids are made up of terminal branches that end in the cells of the fibroid. So if in this example of a tree, if we were to use beads to close up the proximal or the closer parts of these stems, these parts out here stop getting oxygen, and that's why fibroids die. I hope that helped kind of explain that. So I'm going to show you some examples of how well that works. We're going to look at some MRIs, which I think are a beautiful way to look at fibroids, understand why they cause all the problems that they do, and how this treatment works. So this is an MRI we have on the screen, and I'm going to overlay a patient lying on the MRI scanner so we can understand or orient ourselves to what we're seeing here. So this is the patient's front. We're going to see the patient's stomach or front lying on a table here. So the patient's back is back here, and their sides are over here and here. So let's look at that at MRI, and these are some of the bones of the pelvis out here, and we're going to let that scroll. Now let's let that scroll through, and we're going to freeze it here. This whole thing here is the uterus. It is markedly enlarged by huge fibroids. This whole organ is the uterus. The fibroids are these bigger masses inside. And the patient has received contrast dye, so the fibroids are enhancing. We know that they're richly vascularized, and that's helpful knowing that embolization will work to treat these. Here's fibroid here, here, here. Most patients with fibroids have multiple. And you can see that there's even more. If we were to scroll through, there's another one here. All fibroids die from our treatment. Nothing can hide from what we do in the blood vessels. So it doesn't matter how many fibroids a patient has, they will all die. I'm putting up an MRI picture from a normal uterus just to show a comparison. Here's the uterus. This is a different patient, but as a comparison of the uterus size, this is the uterus here. So you can just see how markedly enlarged this patient's uterus is by the fibroids. So the pelvis is a small space surrounded by bone. There's no room for an organ to grow that big. The pelvis only has an opening in the front. And so if an organ in the pelvis grows, you've got bone in the back, bone on the sides. So everything kind of comes towards the front and bulges out the front part of a patient's tummy. Fibroids can also cause problems for its neighbors. Nothing can grow that big without putting a ton of pressure on the uterus neighbors in the pelvis. So these are the main symptoms that fibroids cause. Heavy menstrual bleeding, by far the most common, could be the most troubling. Heavy bleeding can lead to anemia, which can be a significant health problem, health risk. But also pelvic pain and pressure, as you can imagine, from the fibroid exerting pressure on the pelvic floor muscles and other organs. Urinary frequency, the uterus sits right on top of the bladder. And as the uterus enlarges, it prevents the bladder from filling. So the patient feels like they have a full bladder very early when in fact the volume is pretty low. That means frequent trips to the bathroom, getting up at night to go to the bathroom, and painful intercourse. Now, one note about symptoms, it's really up to the patient to decide when the symptoms are severe enough to warrant treatment. So don't let anybody tell you that you have to get your fibroids treated. It's really, there is no cancer potential. And aside from anemia, there's no risk to your health or well-being or longevity because of fibroids. So it's really up to the patient to decide when the symptoms or the problems that fibroids are causing are a big enough problem or disruptive enough to her life to warrant kicking things up a notch and thinking about a definitive treatment to get rid of the fibroids. So that being said, once a patient's decided that she is fed up and ready for treatment, ready to explore treatments, the two options that are usually left, with some exceptions, the two options are hysterectomy and uterine fibroid embolization. So that's what I do. We're going to call uterine fibroid embolization, it's kind of a mouthful, we're going to call that UFE from here on out, okay? So we'll say UFE for what I do. Embolization, by the way, just means modifying blood flow or slowing down blood flow or even stopping blood flow. Any technology we use from within the vessels to stop blood flow is called embolization. And so there's embolizations that we do for all organs virtually. And the uterus is a common one that works really well. So My approach is done completely within the blood vessels. My approach is not an operation, so I think that's important to know. It's a minor procedure done in an outpatient office. You don't feel anything that we're doing. The procedure takes 60 minutes. Patients sleep through the whole 60 minutes. And that's because we do give mild sedatives that put you to sleep, and there's nothing we do that you feel. So there's no need for deeper anesthesia. There's no general anesthesia. We do this in 60 minutes, watch the patient for 2 hours, and then let you go home. So the administration of beads into the uterine arteries takes place in the course of this 60-minute procedure with the sedatives that we talked about. We puncture into an artery with the tiny catheters, like a little angel hair pasta. And you can see on this animation it being navigated through the blood vessels into in this case, the left uterine artery. We end up navigating into both uterine arteries. There's one uterus, but there's two uterine arteries, a left and a right. So we treat both one at a time. And once we've navigated the catheter into the artery, watching what we're doing with x-rays. And here it shows that we're bringing the catheter up close to the fibroid. We actually treat from the main uterine artery so that we treat all fibroids that are present. Once we believe our catheter is in the right place, we inject contrast dye and get an angiogram. So this is an angiogram. It's a beautiful angiogram, a beautiful example. You can see that these are x-ray pictures. The computer has subtracted out the bones, so you can barely see the bones here, the pelvic bones. And so what we see, for the most part, is contrast dye in the arteries. And that's in black, or this dark gray is contrast dye. And what we see right off the bat are these huge arterial branches going to the midline of the pelvis. These are the uterine arteries. Look how big they get. The uterine artery should be as big as this little branch right here. So you can see that to meet that oxygen demand, the arteries have to get huge, and arteries are smart. If the tissue that they're perfusing needs more oxygen, arteries will grow big enough to meet that demand. So what we've done next is advance our angel hair pasta size catheter into this, in this case, the left uterine artery. And that's in this picture here. We've got our catheter in the left uterine artery. We're injecting contrast dye, and we see this dense staining of contrast dye. The contrast goes wherever the blood flow goes. So we know that most of the blood flow is going to two fibroids. There's one here and a smaller one here. We see very little blood flow going to the rest of the uterus. You know, there's going to be more uterus down here and up here. The normal uterus gets very little blood flow. So wherever the blood goes, the contrast goes, but also the beads will go. So most of the beads that we give will go into the fibroids, which is really nice. That's what we want. And I just wanted to show in this slide that what we saw here with our catheter positioned just outside the fibroid is this in real life. So you can see that we can influence what's going on in this fibroid once we get into the blood vessel that's keeping this fibroid alive. Imagine the things we can do. We can inject drugs to treat any diseases that are going on. We do that a lot in the liver. We don't do that in fibroids, but we inject the beads. But I think just as a visual, if we can get this close to a fibroid and affect its function with this degree of accuracy and precision, why use a scalpel to cut it out when it could be this easy to treat? You know, and I think that this visual kind of drives that home. So we've established that we're in the left uterine artery. We now treat the fibroid vessels with the beads. We flood the circulation of the fibroid with the beads. The beads get stuck in the small artery branches and form a stacked column that ultimately closes up the lumen. As we mentioned, a little bit of trickle of blood flow keeps going through. We do that on both sides, and then we're done. That's our 60-minute procedure. I wanted to show some before and after pictures now using the MRIs. And so this was a 43-year-old patient before treatment, showing predominantly one very large fibroid in the pelvis. Again, this is a cross section. So this is the patient's stomach, and this is the patient's back lying on the table. One large fibroid. 5 months later, this patient had another MRI done. And here's what the fibroid looks like now. You see there's no more contrast dye going into the fibroid, and it's taken on a darker picture, which just means that it's devascularized or it's dead. So this fibroid is dead, and it has shrunk quite a bit. By measurements, we know that this fibroid, let's see, I have the measurement here. This fibroid shrunk 75% by 5 months. Now, it's important to note that fibroids are a sphere, and we're just seeing one plane. But if we were to look at all the planes or look at the fibroid as a sphere in 3 dimensions, we would see that the volume of that sphere, that fibroid as a sphere, has been reduced by 75%. And that's what we want. We don't rely on fibroid measurements. We rely on curing symptoms. But I think it's useful to note what happens to the fibroid and the uterus as a whole. This is another patient, a 39-year-old patient with heavy menstrual bleeding. She had multiple big fibroids. Let's let that scroll. You can see one big one here. There's a small one here, big one, small one. There were several. And the uterus is markedly enlarged. This is 15 months. So this follow-up MRI or post-treatment MRI was done 15 months later. So let's get an apples to apples comparison. Maybe that's a good one right there. So you can see that this fibroid is this one here, here is here, and here, right here. This uterus has shrunk markedly. These fibroids are dead. Like I mentioned, all fibroids die. All fibroids get exposed to our treatment and die. So no fibroid can survive what we do. The uterus as a whole shrinks by half. Very consistent number. If the uterus is 200 cc's in volume, it shrinks to 100. If it's 400, it'll shrink to 200. We know that the uterus will shrink down to half of its size. Now, that takes a few months, but it will shrink down to half of its size. And so I just put up a before and after picture here to show what we're talking about. This is that same patient. We're looking at it from a different angle. Now we're looking at the patient from the side. Let's imagine that the patient is standing in front of us and standing sideways. And we're looking at the patient from the side. Her back is on this side of the picture. Her front is on this side. And there are bones of the lower lumbar spine and sacrum here that we're going to see on this MRI as we scroll through it. Okay, so remember, this is the back, this is the stomach, and here's those bones of the lower lumbar spine and the sacrum. This is the uterus. It is markedly enlarged. This was before treatment. There's a big fibroid here, and we get planes of sections, so we need to scroll through to look at all the planes in which these pictures are represented. There's another large fibroid here. Look how high this fibroid comes up out of the pelvis. And actually this fibroid, you can see right here is the defect caused by the belly button, which makes this equivalent to a 20-week uterus or equivalent to the size of a 20-week pregnancy. And that's how gynecologists talk about uterine size. So this is equivalent to, was that a 5-month pregnancy? So the uterus is markedly large, and it's coming up to, this is the L5 vertebral body, this is L4. So the uterus is coming up to L4. Now let's look 15 months later. This is that same 39-year-old patient with really heavy menstrual bleeding. And let's let that scroll through. You stay there. And let's freeze it there. This is as high as the uterus goes. So here's that L4 vertebral body. The uterus was way up here. Here's the belly button. So the uterus had come way up here. You can see how this uterus has shrunk more than 50%. And you can see that the fibroids have become really dark on this MRI. They're dead. They're shrinking. It's okay to leave them in there. That tissue just gets reabsorbed by your body's white cells, and they slowly shrink down to just about nothing. And we measured this I think we measured about a 79% volume reduction for that uterus. So we can measure the uterus and get pictures all day, but what we really do this for is to cure problems, that are disrupting a patient's life, to make these symptoms go away and get patient back to a normal life quickly. So how does UFE measure up in solving problems for patients? Well, many studies have been done to tell us how well that works, but the best studies are called randomized controlled studies. They have been done. Large numbers of patients were randomized to either UFE or hysterectomy and then followed for 10 years. So it's a very good quality study with a really long follow-up. Patients were followed for 10 years to see how well they did, not just in the first few weeks or months, but for 10 years. So here's what we know. The most important measurement is patient satisfaction, and that's here. Patient satisfaction that the treatment fixed the problem. Whether the treatment was UFE or hysterectomy, did the treatment fix the problem? And these patients were asked 10 years later. And what we find is that in very high numbers, both groups of patients agreed that the treatment fixed their problem. This difference, there's a little bit of difference here. They're both high numbers. They're both hovering around 80%. Statistically, no significant difference. So that means that the small difference that we see here is explained by coincidence and not by a real benefit between one treatment or the other. After 10 years, would the patient recommend the treatment to a friend? And both groups were very high and both groups were equal without any significant difference. So the bottom line is a UFE, a procedure done entirely through the blood vessels, can match hysterectomy in terms of patient satisfaction that the treatment fixed the problem even 10 years later. Here's what else we know. The experience of the patient going through the procedure and getting back to normal life was significantly better in the UFE group. Sorry, this should be UFE. Sometimes I call it uterine artery embolization, but for consistency, think of this as UFE. So even after 10 years, this is more relevant to the immediate post-treatment course, with the procedure time, hospital stay, time to get back to work, and blood loss, UFE was far and away significantly better compared with surgery or hysterectomy. Let's drill down on some of those numbers. In procedure time, 60 minutes, much faster than a hysterectomy. No hospital stay. This is entirely an outpatient treatment. If I hadn't said that before, patients go home the same day. We never hospitalize patients. We actually do these in our offices. So we do these in outpatient offices. So the patient doesn't feel like they're in a hospital, nor will you ever need to be in the hospital. The back to work in 10 days, much, much faster than the time back to normal life after a hysterectomy, and not even a drop of blood loss. We are actually closing blood vessels, not causing bleeding. So nothing we do could or does cause blood loss. We're not doing any cutting. No, there's no wound that could bleed. And hysterectomies do have blood loss, and that can be a big problem in some cases. So a significant advantage to UFE in terms of the experience going through the procedure and recovering from the procedure. UFE side effects, there is significant pelvic pain that can happen. Killing fibroids causes pain, and it's been described to me as intense menstrual cramps. And that can be intense enough to need strong medications to treat. And that pain can go on for about 48 hours, usually less, 48 hours at the most. So that first night after the procedure, patients usually need high doses of Tylenol and naproxen and maybe a little oxycodone to stay comfortable. That being said, we've never had to admit anybody to the hospital for IV, intravenous pain medications. So we're always able to get patients comfortable using the pain pills that we send patients home with. The malaise, it kind of describes like a flu-like syndrome with muscle aches all over, tired, low energy, low appetite. That can go on for about a week. And so each day better than the last. Patients feeling better as each day goes along. So patients are usually feeling pretty well back to normal in 10 days, back to normal life before that, more like a few days to a week, back to normal life, feeling back to normal after 10 days. The reintervention rate is something worth mentioning. And this is the one area where hysterectomy has the advantage. So after 10 years, the study investigators went back and looked at how often a patient needed a retreatment for not just fibroids, but for problems caused by the initial treatment. So in the UFE group, after 10 years, 30% of patients went on to have another treatment for fibroids. And that's usually because new fibroids can grow and cause problems again. The hysterectomy group, of course, did not have any potential for new fibroids growing because the uterus is gone. But hysterectomies can cause their own set of problems. They can cause chronic pain and pelvic floor problems causing incontinence, requiring extra surgery to fix incontinence was the most common, or adhesions causing chronic pain. So in the hysterectomy group, 17% went on to have additional operations to fix the problems caused by the hysterectomy. So this is a significant difference, and this is worth considering for patients that are trying to choose between their two options, the 30% versus the 17%. So just to wrap up what we've learned, UFE is fairly invasive. It is so minimally invasive, you barely know we were there. I call it microinvasive. It is very safe, and yet we can match hysterectomy in our 10-year patient satisfaction. So we can match the results you get from hysterectomy. No hospital stay and a 10-day recovery. By far, this is the fastest way to get back to a normal life after treating fibroids. And I think of the decision as kind of a balance that each patient has to evaluate on their own and decide what's best for her. On the one hand, the UFE can get you a quick recovery back to normal life, but the price to pay for that is that 30% retreatment rate. The hysterectomy, on the other hand, takes longer to recover. It's a surgery. You've got wounds that need to heal, and there can be a course of pain and other problems after surgery that take 6 weeks to recover. And there's that 17% reoperation rate for problems that hysterectomies can cause. So it's really up to the patient to evaluate what's best for her, where she feels like this comes down for her, what's best for her life, because the two treatments give you equal and high patient satisfaction even after 10 years. So this should not be a factor in choosing between one or the other. It's really, where do you come down on what you prefer for your recovery and the potential for retreatment down the line? And I'd like to thank everybody. I'd like to thank Paul and everybody for joining us. And I'd like to ask Paul if there's any questions.
Great. Thank you, Dr. Wood. If you wouldn't mind stop sharing, I'm actually going to put up the phone numbers for all the clinics in which we have here so that everybody has the ability to be able to see how they can go ahead. Here we go. How they can go ahead and schedule an appointment. There have been a couple of questions, though, that have come in. One question is this covered by insurance?
Oh, it certainly is. Everything we do is covered by insurance, and this procedure has been around for 25 years. So it's well studied, it's well accepted, and it is covered by all insurance, all commercial insurance, Medicare, and we are in network with all the major insurance companies.
Fantastic. The other question is, if I have fibroids, can I just come to you, or do I need to get tests from my gynecologist?
You could actually just come to us. Now, we like to make sure that patients have had their well women care. And so we like to make sure that the prudent screening exams have been done, such as a pap smear and perhaps an endometrial biopsy if the patient has heavy bleeding. And that's kind of a gynecologist's decision. So we do like to make sure that those bases have been covered. But that being said, if a patient has had fibroids diagnosed and they've held off on deciding on a treatment, we can certainly talk to the patient. It doesn't hurt to just talk to us about a woman's options and determine for yourself what's best for you.
Fantastic. Well, that is actually the last question in which we have. I do want to let everybody know, though, if you do go to our website, advantage-ir.com, you'll see procedures. If you click on that and go down to uterine fibroid embolization, we actually have a patient story out there. Taniqua actually had her UFE procedure done, and it just talks a lot about what she went through, her experience. So if you really want to hear from an actual patient, it's a great video for you to be able to see. I'd like to thank everybody for taking the time to be with us today. Thank you to Dr. Wood. We will record this and put it out on social media as well as our website. Certainly, if you have any questions, please feel free to call any of these numbers that you see on your screen. Thank you, everybody, and have a great day.
Thank you, everybody.